Good morning again, and thank you for allowing us to present this work. We have no disclosures. Magnetic sphincter augmentation, or the Linx device, is a device that is placed at the gastroesophageal junction through a window developed between the posterior vagus and the esophagus. Using a proprietary sizing device, we can determine the size based on number of metallic beads and then place that at the gastroesophageal junction. Once it is in place, it expands to allow food boluses to pass, but then contracts down to prevent reflux. Since its introduction to the market, it has been pretty well vetted, even by this society here, and found to be a safe and effective option for patients with GERD. When it was approved in 2012 by the FDA, it was originally for patients who had clinical evidence of GERD that had no prior foregut surgery, no or a small hiatal hernia less than 3 centimeters, and BMIs less than 35. Now, most surgeons who are familiar with the operation of the device have now began to use this under expanded indications. We have sought to review all patient outcomes and satisfaction after Linx placement for expanded indications and then compare those to standard indications. We performed a retrospective study over a 1-year period that was associated with a prospective perioperative survey. Patients were placed in either expanded or standard indication groupings. Expanded indications included patients who had clinical evidence of GERD, who had had prior foregut surgery, a larger hiatal hernia either found preoperatively or at the time of the operation, or a BMI of greater than 35. All patients were followed out for at least 3 months and completed both a preoperative and postoperative GERD quality of life survey. This data, along with our perioperative data, was then compared between the expanded and standard indication groups using descriptive and comparative analysis. 28 patients met inclusion criteria, with 15 of those patients meeting the expanded indications grouping. This graph breaks down those who had expanded indications. The majority of patients had had prior foregut surgery. The majority of those patients were those who underwent prior bariatric surgery, the vast majority, all but one patients, having lap sleeve gastrectomies. We did have one lap Roux-en-Y gastrectomy. The average age of our patients was 44, with slightly more males evaluated than females. BMI average was at about 28, and all patients required preoperative medication with an average duration of 4 years and an average dosing of over 40 milligrams daily. Operatively, we found that the majority of patients required a hernia repair at 23 out of 28 of some sort. The median Linx size was 15 beads, and the average operating time was 101 minutes. Most patients stayed at least 1 day in the hospital. We compared our expanded and standard indications for this data and found that there were no statistical differences excepting for the Linx size, which was on average 2 beads larger in our expanded indications group than our standard indications. When we looked at our preoperative and postoperative survey results, we found no differences between the two groups, and all patients had at least a 60% improvement. Looking further at improvement, we found that in our expanded indications, there was on average 74% improvement based on differences between preoperative and postoperative survey scores. Most patients were satisfied, in fact 100% in the expanded indication group. And although rare, we did find equivalent rates of prolonged dysphagia between the two groups. There are limitations to our study. It is a small sample size and difficult to interpret the data that we have been able to achieve in this study. There's also heterogeneity in those patients that underwent the operation for expanded indications. And finally, this is a retrospective study, and so therefore it's subject to the well-known biases of those types of studies. In summary, we can say that we know from our data that prior bariatric surgery was the most common reason for a patient to undergo this operation in the expanded indications group. Complication rates were no different between the two groups, and survey-based outcome and patient satisfaction were also no different. From this, we can conclude that the Linx offers a safe and highly effective new option for patients with GERD. And although data on this topic is pretty sparse and our sample size is a little bit limited, We feel that this appears equally effective in patients with larger hiatal hernias, prior foregut surgery, and those patients with higher BMIs. Thank you, and I'll be happy to entertain any questions.
Thanks for a great presentation. Young Choi from Eisenhower. So I think by now most people who do Linx accept the fact of prior foregut surgery, large hiatal hernia. I know there's studies going on about using these for large hiatal hernia, and now they're actually talking about doing a complete dissection. The question is, did you tease out the 3 different expanded indications that you had? And so, like for BMI greater than 35, it's been shown that Nissens do not work as well for BMI greater than 35. So it'd be interesting to see if you compared the results of a Nissen versus the results of a Linx for patients greater than 35. And within the study, did you break those into subsets to see which one of those expanded criteria patients had better outcomes than others?
Yeah, good question. So you caught us. There was one patient with a BMI of over 35. So comparing that data to either our Nissen data or national data, it was not worth doing, as we wouldn't be able to find anything significant from that. We did tease out all the expanded indications and found similar results where there were equivalent rates of complications and improvement for pre- and post-operative surveys. The second thing I wanted to address in your question was that comparing our results to a Nissen, in the vetting of this device, there have been multiple studies looking at its comparison to lap Nissen. And so we didn't feel that it was necessarily helpful or added anything to the literature to do that at our institution.
They did do that for vetting, but that was for BMI less than 35 because that's where the prior indication was. So the question is did you compare for patients greater than 35? Because otherwise, yeah, the vetting was there for Nissens for less than 35.
Right.
But I do not believe, unless I missed it in all their vetting, that they did comparisons for patients greater than 35.
Yeah, no, or for any of these expanded indications. That's true.
We'll take one more question due to limited time here.
Okay, thanks. Jason Fluke from BAMC. It seemed like you said in the post-sleeve patients who were having the Linx placed that a lot of them still required hiatal hernia repair at the Linx placement. Is that correct?
Yes, most patients overall did, and for lap sleeve, that was true for about half of them.
So, do you know if those patients who had the sleeve what percentage of them had hiatal hernia repair at the initial sleeve operation? Was it something that wasn't repaired that was already there? Something that was repaired that recurred? Because that's still really a hot topic item in sleeve. What to do with the very small hiatal hernias that may or may not be significant? That's
a great question. So none of the patients that we had included in this study had a hiatal hernia found at their initial operation. Anecdotally, I can say that is not a dissection that we carry out to the point where we would maybe be able to even know that. And that's, like I said, that's anecdotal. So it depends on where you're able to adequately identify your angle of His. If you're not able to do that before making your resection and you continue to make that dissection in the hiatus, then there are times that we find it and we repair it. None of these patients had that situation.
Thanks a lot.
Sorry, one quick plug. So we would like to expand this to all DoD facilities. So if there are people that are placing the Linx device in any of these expanded indications, we're working on an IRB protocol to make this a multi-center trial to sort of pool our data. So please, if you're interested or know anybody, contact me.